we'll be talking about the vestibular labyrinth being involved in the cochlear knot. And this is what's been described at the moment as recurrent peripheral vestibulopathy. So as if we don't, we don't have two conditions to differentiate between. We also have a third condition. We have Meniere's disease, we have vestibular migraine on one end, and the third possibility, recurrent peripheral vestibulopathy, or if one can avoid using the term endolymphatic hydrops, at least a pathophysiological involvement that may be similar to Meniere's disease, but involving only the vestibular labyrinth. And with regards to my patients and who I see many such cases of frequency tuning where the pure tone audiometry is normal. So this phenomenon, the presence of this condition, what we at the moment call recurrent peripheral vestibulopathy, may not be as rare as previously considered, and may be more frequent. And we may be seeing these patients already in our laboratory. So this is something that we need to keep in mind. And my argument here is that doing VEMPs, if you are able to do VEMPs, and I hope you will be able to do VEMPs if you are not doing them yet, helps you in determining if your patient has either vestibular migraine, Meniere's disease, or this third condition, which frequently shows a normal pure tone audiogram. I show a similar case, but this is again interesting as well. This was a 56-year-old female with probable Meniere's disease, and she does have Meniere's disease. The pure tone audiometry was reported by the patient. I didn't have the pure tone audiogram with me, but she reported that there was low frequency loss found with regards to the left ear. I did the CVEMP, expecting to see the frequency tuning for the left ear on the same side as the pure tone audiometry, but to my surprise, I saw this frequency tuning not on the left, but on the right. So this is the left ear, and this is the right ear, 1 kilohertz and 500 hertz. And instead of seeing a larger amplitude on the left, where the pure tone audiogram was abnormal, I saw a frequency tuning on the right. Very interesting. So I haven't seen anything published similar to this, and I hope to publish this case soon. But it appears that we have a case of Meniere's or Meniere's-like condition, if you like, in this case. But the hydrops, if we, again, we believe that this is the cause of these conditions, is affecting the cochlea on the left, but the saccule or the vestibular labyrinth on the right. So we have differential involvement of the two labyrinths, apparently, in this patient, or you can argue along this point, and you can give me your own interpretation, but why would this be important, since we know that the patient has Meniere's disease? Well, one that comes across my mind is that if you decide to do intratympanic steroid injection for these patients, in which ear will you do the steroid injection? Will you do it in the left ear where the audiogram was abnormal, or would you do it in the right ear where the CVEMP was abnormal? An interesting question. I don't have an answer for you yet. Perhaps if the vertigo is the worst symptom for the patient, you may decide to do it on the left, on the right, but then you may argue, but you don't want the hearing to deteriorate on the left. Good arguments, but this is something to consider. And here I show a case of possible central cause of vestibular dysfunction, or this can produce good arguments as well. So I present here an 84-year-old lady with long-standing symptoms of vague dizziness, not described as vertigo per se, over many decades, and she has been helped all this time. Air calorics revealed diminished, this was reported as being diminished bilaterally for both ears. The referral letter from the referring physician asked me to rule out a bilateral vestibulopathy, although he told me that this was not compatible clinically. He did not believe that the patient had a bilateral vestibulopathy, even though the air calorics were diminished bilaterally. And I went ahead and I did the CVEMPs in this patient, and OVEMPs as well. So these are the CVEMPs for the left ear and the right ear. The OVEMPs as well. This is a 86-year-old. Even though you have some EMG in the background, like I said in the first lecture, you should do more than one trace. And as you can see here, you can see a reproducible response here, which represents the OVEMP. But probably better here than on the right, but you can see that they are in exactly the same place. So perhaps it's better here. So normal responses with regards to the CVEMP and the OVEMP. And what's interesting here is that the CVEMP records from the inferior vestibular nerve, the OVEMPs records from the superior vestibular nerve, but the air calorics records not only with regards to the lateral semicircular canal, but also the superior vestibular nerve. So why is there a differentiation with regards to superior vestibular testing, where one test is normal and the other test is abnormal? Well, when you go into the literature, there is the known characteristic, the possibility that one needs to keep in mind of isolated horizontal canal involvement. That it's possible to have isolated horizontal canal involvement in some of your patients, and this can describe the differentiation here. And this differentiation here appeared because VEMPs were performed. So what would cause, so again, this publication was published by Chen and Hamaki a few years ago, emphasizing the fact that you can have isolated horizontal semicircular canal involvement that looks like a bilateral vestibulopathy, especially when you see such findings on both sides. And what can cause such a selective finding? There are reports in the literature and also by word of mouth that because of the complex nature of the vestibular nuclear complex in the brainstem, certain lesions in the vestibular nuclear complex can affect the vestibular labyrinth selectively. But there is also the strong feeling, and this is also possibly, this is also maybe will be true in some cases where a vascular involvement can also lead to such selective involvement of the vestibular labyrinth as well. So the bottom line with regards to this case is that yes, you can have differentiation between paramedical examinations, not because of poor technique, but because of either selective involvement of specific parts of the vestibular labyrinth. Hence, the beauty of using all these examinations, of course, based on your differential diagnosis, to use in your patients a full battery that would completely cover all your structures in your ear, your pure tonal audiometry, caloric responses, VEMPs with regards to the otolith and the utricle, caloric responses for the horizontal canal. We have the pure tonal audiometry for the cochlea, and also we have at our disposal now the possibility of doing video head impulse test that can look at other semicircular canals, not only the horizontal semicircular canal, but the vertical, the horizontal, and the posterior semicircular canals as well. So yes, depending on your differential diagnosis, but the beauty of you combining all this together is that you can home in on where the lesion is with regards to the inner ear. And this is my final case, a young male with dizziness for 4 years. The symptoms were reported to have begun after diving. So of course, what comes to mind is perhaps a development of the superior semicircular canal dehiscence, or a development of a third window, if you agree with me, with regards to the high pressures involved with diving. The CT, unfortunately, was unavailable for review for me. As soon as the patient performed the CT, they went abroad. But after Professor Manoj's Agarwal's lectures yesterday, I was definitely in the mood, and I definitely did want to see that CT. And after his lectures, I would have liked to see those CT scans again. They were reported as normal, although, like I said, I did not see the CT exams myself, but this patient had large CVEMP responses. I show here the CVEMP response on the left here. Both of these responses are recorded from the right ear and the right sternocleidomastoid muscle. This is the CVEMP and this is the EMG. the CVEMP showed an amplitude of 90 microvolts, but the EMG was 8, giving a corrected amplitude close to 10 microvolts. The upper limit for our laboratory is 4.4 or maximum 5. This patient went way above that. This is an example of a case where indeed, if a CT was reported as normal and you haven't seen it, and you get to see a CVEMP response or an OVEMP response that was larger than normal, you would want to see the CT scan yourself. And I hope to see it in the future, if I can follow up this patient at some point, which I will do. But I suspect that there is a third window syndrome going on, or perhaps something similar, creating this large amplitude response, which would go with the fact that the history of diving and the symptoms appearing soon after diving. If you agree with me, but of course, this can be argued. So these are the cases I wanted to show you. Again, this is my email here, but of course, there are other applications of VEMPs that are reported in the literature, which I have also reported in the recent review I did with Dominic Strauman, I believe last year or the year before it was published in Clinical Neurophysiology. I have to send that to you as well. And also, if you have cases that you have in front of you, and you wonder if a VEMP would be useful, or if you do the VEMP in such cases and you wonder how the VEMPs can be interpreted based on the case that you have in front of you, or you saw yesterday or the day before, you can send me an email with regards to those cases, and I can recommend how to perform the VEMPs in those cases and what you expect the VEMPs to show if your differential diagnosis if your diagnosis is what you believe it would be. Thank you very much.
Thank you so much. Are you able to hear me?
Yes.
Perfect. I'll ask you the first question, which comes from me personally. Do you have any restrictions or any contraindication for performing OVEMPs? I know CVEMPs, if I'm using AC, it would be a conductive hearing loss, but any visual or any other restriction you will take or contraindication for OVEMPs?
That is a good question. Well, the answer to the contraindications is no, if you know the contraindications beforehand. What I mean by that is that, okay, hyperacusis, I will go ahead and do it. And if the patient does not want me to perform the study because they find the examination is uncomfortable, then I will stop the study and not perform the study. But okay, even if a patient, and I have had 1 or 2 cases of hyperacusis being mentioned, but I went ahead and did the VEMPs and I got good VEMPs and the patient was okay. Now, the reason I laughed a little bit is because I had a case last month of a patient who came in. I did the CVEMPs, everything was okay. I started to do the OVEMPs. The mark was up on the wall behind her on the head. Like I said, I routinely do the study with the patient lying down. So the patient has to look up while they're, and she wasn't looking up. And I asked the patient, are you looking at the mark on the wall? And she said, yes, but I could see, but of course you have to look at the patient. And it looked like the patient was looking directly above her. So I stopped the study because I wasn't getting an OVEMP response. And I sat the patient and I determined there, after my attempt, that the patient had up gaze ophthalmoplegia, which was not mentioned before in the history. And I actually sent this to the referring doctor. So a case of up gaze ophthalmoplegia that prevented me from doing the OVEMP. But of course, this was seen after. Now you may say, it would have been easy for you to call this an unobtainable response and say, yes, the patient has bilateral utricular dysfunction or superior vestibular dysfunction or something happening in the upper part of the brainstem. Yes, indeed, but clearly there has to be a habit of looking at your patient and not just at your recording monitor to make sure that they are cooperating with your study. You make sure, even a patient says to you, yes, and they look like the sort of patient that will cooperate and they've been doing everything fine up to that point, with regards to these specific instructions, lifting the head up from the pillow, looking direct up as much as you can, they do need some encouragement to do it correctly. This is not their fault. This is a movement that we don't do on a daily basis. So they need to be specifically told how to do it patiently. You have to look at the patient. You have to see how they lift up the head up from the pillow, how they look. They clearly have to look up as much as they can. You need to see the whites of the eye below the pupil, and to see the pupil go under the upper eyelid. And then you can be sure you will get a good response.
Okay, next question is cause of better response at 1000 hertz versus 500 hertz, I think in many cases.
What is written in the literature is basically we're talking about physics, and we're talking about how waves of specific frequencies pass through a fluid field environment. And the literature agrees with this, although you won't find the literature having placed the recording needle in these sacs and saying, yes, the frequency was better because of the pressure being recorded by this needle within the vestibular labyrinth, that somehow the increased pressure either changes the direction of movement of the sound waves within the endolymph, and the high pressure is favors a high frequency to move through the liquid, or the high pressure located in the vestibular labyrinth somehow changes the reaction of the hair cells to the sound waves, and therefore, perhaps with the high pressure, somehow they respond better to the higher frequency.
Okay, next question. In your experience, does the VEMP relate to staging in Meniere?
Very interesting question, and you're maybe probably referring to a paper published 3 weeks ago, if I'm not correctly, about using VEMPs to alternatively stage Meniere's disease and not just use pure tone audiometry.
I will share it. I will share it on the group. I was hoping to do so soon, so I will share it for you.
Yes, I've actually got the paper myself, and I'm actually in the middle of reading it. So it's interesting. I've actually reviewed this in 2014. It is possible, yes. And in fact, if I remember correctly from the review that I did, you could actually have your stage 1, 2, 3, and 4. And I actually was able to conclude that using VEMP could actually split these stages into 2. So you could actually get a 3A and a 3B, depending on the VEMP findings. So yes, if the question is, do you think it would be useful to use VEMPs to stage Meniere's disease? And I say, and my answer is yes.